On May 13, 1995, the bustling corridors of Kikwit General Hospital became a silent battlefield, where a single patient's fever would ignite a chain reaction that would claim more than 300 lives and forever alter the world's understanding of viral hemorrhagic fevers. In the humid heart of the Democratic Republic of Congo, an unsuspecting physician walked into a ward that would soon be overrun by a pathogen that had never been seen outside the remote forests of Central Africa. The virus, later identified as the Zaire strain of Ebola, spilled from the bedside into the very heart of the hospital, exposing the terrifying consequences of inadequate protective gear and unprepared health systems. The story began in early March 1995, when a 44-year-old man from the village of Bonde arrived in Kikwit with a high-grade fever, severe abdominal pain, and vomiting blood. Within days, his condition deteriorated into a rapid, unrelenting hemorrhage. He was admitted to the infectious disease ward, where doctors, lacking both the equipment and the training to recognize a novel filovirus, treated him as if he suffered from a common viral gastroenteritis. The patient's blood, soaked in the same cotton sheets and syringes that would later be reused on dozens of others, became the invisible conduit for the virus. Within a week, the ward's nurses began to develop unexplained fevers, their skin turning mottled and their gums bleeding with the slightest pressure. By the time the first laboratory confirmation arrived, an urgent PCR test sent to the Institut Pasteur in Belgium, over 24 staff members had already fallen ill. The virus had slipped past the thin veil of gloves, gowns, and face masks that were either missing, ill-fitted, or, in many cases, completely absent. The lack of proper barrier protection turned the hospital into a crucible of infection, and the pathogen leapt from patient to caregiver with ruthless efficiency. By the end of May, the outbreak had spread beyond the hospital walls, infiltrating homes, markets, and the very streets of Kikwit. The World Health Organization dispatched an emergency team led by Dr. Peter Piet, the virologist who had first identified Ebola in 1976. Their arrival marked the beginning of an intense, coordinated response that would blend epidemiology, clinical care, and desperate improvisation. The WHO team set up an isolation unit in a local school, equipped it with the scant supply of personal protective equipment, PPE, that could be sourced, and instituted a strict, no-touch protocol for anyone entering the contaminated zone. Key facts emerged quickly. The case fatality rate in Kikwit hovered around 81%, far higher than the 50% reported in earlier outbreaks in Zaire and Sudan. The virus's incubation period ranged from 2 to 21 days, a window that allowed asymptomatic carriers to move freely through the city before showing any signs of illness. Contact tracing proved a monumental challenge. Family members, traditional healers, and even funeral processions became vectors, each interaction a potential spark for new infections. Over 2,000 people were identified as contacts, of whom 700 were placed under strict quarantine. Amid the chaos, a desperate trial of therapeutic interventions began. Doctors administered ribavirin, an antiviral drug that had shown promise against other RNA viruses, but it proved ineffective against Ebola's aggressive replication. In parallel, a handful of patients received convalescent plasma harvested from survivors, an early glimpse of what would later become a cornerstone of Ebola treatment. The trial was informal, uncontrolled, and fraught with ethical dilemmas, yet it underscored a vital lesson. Without rigorous clinical studies, even the most well-intentioned interventions risk becoming placebo. When the death toll finally began to plateau in early July, the WHO team turned to the autopsy suite to uncover the virus's lethal choreography. The pathologists, working under strict biosafety conditions in a makeshift BSL-4 laboratory, discovered massive hemorrhage in the liver, spleen, and adrenal glands. Microscopic examination revealed viral inclusion bodies within endothelial cells, explaining the pervasive vascular leakage that characterized the disease. The virus was also detected in the brain, lungs, and gastrointestinal tract, confirming its systemic reach. These findings would later inform the development of diagnostic assays that could detect Ebola RNA within hours, a critical tool for future outbreaks. The aftermath of the Kikwit crisis rippled far beyond the borders of the Congo. International health agencies rewrote infection control protocols, mandating double gloving, impermeable gowns, and face shields for any contact with suspected hemorrhagic fever patients. The incident catalyzed the creation of the Global Outbreak Alert and Response Network (GORN), a collaborative framework designed to mobilize resources at the first sign of a pandemic. In the laboratory realm, the Kikwit outbreak spurred investment in high-containment facilities across Africa, enabling scientists to study filoviruses safely and to develop the first experimental vaccines, such as the RVSV-Zebov candidate that would later prove pivotal in the West African outbreak of 2014-2016. For the survivors of Kikwit, the psychological scars remain as profound as the physical ones. Many returned to communities that still feared their presence, while others became informal educators, teaching families how to recognize early symptoms and how to safely handle the bodies of the deceased. The city itself rebuilt its health infrastructure, installing dedicated isolation wards and stockpiling PPE for future emergencies. Yet the memory of a hospital turned into a vector of death lingers, a stark reminder that the line between healer and host can vanish in an instant when protective barriers fail. Subscribe to the Autopsy Files for more stories like this.